In this study conducted at Institut Curie and Institut Mutualiste Montsouris, we looked at 100 patients with stage 3A non-small cell lung cancer. For those patients, strategies that are possible include chemoradiation in patients with non-resectable disease, or in patients with resectable disease, surgery, either with neoadjuvant chemotherapy or followed by adjuvant chemotherapy. So it's very complex because the decision-making is based on resectability, which has not been that much defined for those 3A, stage 3A patients. We know that the size, the location of the tumors, the need for a pneumonectomy, the number of lymph nodes were reported as drivers of the decision-making to perform surgery or not. But at the end of the day, the decision is made at a multidisciplinary tumor board. So in this study, we wanted to assess the reproducibility of our multidisciplinary tumor board in deciding for surgery versus chemoradiotherapy for those patients. So we discussed those patients for the first time, part of the clinical management of the patients, and we randomly discussed again those patients at a subsequent tumor board 3 or 4 or 6 months after. And the result was that we were consistent in the decision to go for surgery or not in only 70% of the patients. So this highlights the complexity of the decision-making, the definition of resectability in patients with stage 3A non-small cell lung cancer. And this is very important now because we are in the setting of optimized strategies for those patients. Chemoradiotherapy followed by durvalumab from the Pacific trial, and in patients considered as with resectable disease, neoadjuvant chemotherapy plus immunotherapy, the Checkmate 816 trial, or surgery followed by adjuvant immunotherapy, IMpower010, or the PEARLS trial with pembrolizumab. So again, stratifying the patients accurately, surgical approach with neoadjuvant or adjuvant treatment versus chemoradiotherapy combined with immunotherapy, it's very important to clearly define which are those patients. And our data showed that this is unclear, even if in our center, which is one of the top 3 centers for the surgical multidisciplinary management of patients. So what are the recommendations then? Well, I would recommend any tumor board to do this kind of exercise because at the end it helps to increase the reproducibility and to understand what are the drivers within a multidisciplinary team of the decision making. At the end, the survival of patients was similar in the 2 groups, whatever was a strategy, but also there was no significant statistically significant survival difference in patients with consistent decision versus patients with discrepant decision. So this is what we have, and the next step would be probably to assess that from one multidisciplinary tumor board to another, so working with other teams to validate those findings.